Thank you. Very good afternoon to all of you. Happy to see you again. Today, we are going to learn about the gastrointestinal symptoms session 2, that is on intestinal obstruction. This session will be taken by Dr. Vineetha Rijju, who was the last session faculty. We all knew her, so no need of further introduction again and again. So we know her. So, ma'am, welcome back and over to you.
Hi, good afternoon to all. So let me just try to share my presentation. Yeah, my slides are moving.
Yes, ma'am.
Yeah, okay. So, hi everybody. Nice to see you all again. And we will be continuing with gastrointestinal symptoms. And last class, we saw how to manage nausea, vomiting, constipation. And today, we will be looking at how to manage bowel obstruction. So many of you must have seen bowel obstruction patients who come to you with complaints. And what complaints do you think they would be coming to you with? Yes, can we use the chat box? What symptoms will or some signs will these patients be coming to you with? Or you are going to a house at a home visit and you are seeing a patient there and they are telling you a few symptoms and immediately you think, am I looking at a bowel obstruction? Yes, Ms. Kanchan says abdominal distension. Some patient who has a lot of abdominal distension, yes. Anything else? Abdominal pain, Liana. Miss Liana says abdominal pain, yes. So someone who's having an abdominal pain and abdominal distension, yes, Mr. Castanero says abnormal bowel movements. Okay. And Miss Nancy says constipation, vomiting. Yes, they would have trouble opening their bowels and they could have vomiting. Yes. And yes, Anamika, Miss Anamika also agrees to that, vomiting. So how do you think you are going to manage them? Yes, Suman, we have a lot of answers coming here. Suman also says that there will be loss of appetite for the patient. Yes, so we have a lot of answers here. Abdominal distension, abdominal pain, vomiting, then constipation, change in the bowel movements as in constipation, then loss of appetite. And how will you manage them? Yes, Ms. Aditi says it could be a very tight abdomen, like a hard abdomen with all the distension. Okay. So there is some obstruction, isn't it? Yes, Ms. Kanchan says you can take an X-ray of the abdomen, erect and supine. Wonderful. That's just a perfect answer there. You are going to probably want to have an X-ray abdomen, erect and supine. But sometimes, and probably have a NG tube also inserted, is what Ms. Kanchan said. Yeah, and sometimes you just happen to be at a home setting where you are not able to transport the patient for your X-ray, or you are not, you do not have the NG tube in hand. Okay, so but you need to make a diagnosis, isn't it? Because our management is also going to depend on that. So you do think it is an obstruction, but how do you know where the obstruction is? Your X-ray abdomen is going to tell you whether there is an obstruction. We will see more about that in our coming slides. But how will you know where exactly the obstruction is? Yes, Ms. Nancy says palpation. Well, palpation, okay. Right. Probably Miss Nancy meant that, if you palpate and are able to feel the hard fecal masses. Okay. Again. Yes, I know. I'm still in this first slide. Before I get to it, I just want to have some discussion on what everybody knows. Yes. So how else will you know where the obstruction is? So this is what we are going to do. We are at the home setting and we may not know where the obstruction is, but our clinical impression about the patient is telling us that the patient could be having a bowel obstruction, and we have to manage the patient's symptoms and manage the condition accordingly. Okay, so what our class today is going to tell us is how to classify the intestinal obstruction and what are the signs and symptoms of obstruction, and how do you come to a diagnosis that it is an obstruction of the small intestine or obstruction of the large intestine, and how will you manage such a situation? What treatment are you going to do? So tell me one thing, how will you understand where the obstruction is? Is it in the small intestine or the large intestine? Yes, answers? In the chat box? How will you understand where the obstruction is? Via a barium enema is what Mrs. Sumit says. Okay, a barium enema will let us know where the obstruction is. Anything else? Anything else that will help you know? Because the management is also a little different. So we will find out. Okay, endoscopy. So we have answers over here coming as some interventional techniques like barium enema, endoscopy, all this, which will probably tell you where the obstruction is. What if I tell you, you will be able to know where the obstruction is without any of this by just talking to the patient and examining the patient? Let us find out how it is. All right. So classification of intestinal obstruction. Intestinal obstruction, yes, this is a case scenario. Okay, so Sarah is a widower. She's a 62-year-old woman who was diagnosed with stage 4 carcinoma of the stomach with mets to the peritoneum and the anterior abdominal wall. She had a palliative distal gastrectomy done, followed by chemotherapy. Unfortunately, a repeat CT of the abdomen after 2 cycles of chemo showed that she was progressing in her disease. Okay, so we are going to get back to the story of Sarah after a couple of slides. So now coming to the classification of intestinal obstruction, I would say that we could classify intestinal obstruction into mechanical and non-mechanical. We do know that there is something obstructing the intestine, isn't it? There is something obstructing the intestine, which is causing the obstruction there. So what could it be? It can be mechanical, or sometimes it can just be that there is no function for the intestine. The intestine is basically stuck because there is no peristalsis. There is no forward movement. This happens in paralytic areas. Okay, you call it an adynamic bowel. Okay, and it is called a functional obstruction. It is because there is absence of normal peristaltic contraction. And in such obstruction, the pain is less. The bowel sounds are absent. Okay. And when it comes to mechanical obstruction, this can be further classified as, is it a sudden obstruction that the patient had, an acute, or is it something which was chronic, which has been going on over the past few days? Or is it in the small bowel? Is it in the large bowel? According to the site, you can classify it. Or according to the nature, is it a simple obstruction? Is it a closed loop obstruction? Or is it a strangulated? If it is a hernia of the loop of the intestine, sometimes it twists around and it gets strangulated. This itself can cause obstruction. Whether the obstruction, something which is occluding the opening of the intestine, is it actually sitting inside the intestine? It is called intrinsic. Is it actually sitting outside the intestine wall? It is called extrinsic. Is it within the intestinal wall, which is growing into the lumen of the intestine? It is called intraluminal. Now, dynamic obstruction, that is the second entity, it can be further divided into simple, when there is only one obstructing point and there is no vascular compromise. See, what happens mostly is that, when there is a hernia and there is a strangulation that is happening, most often it happens that the blood supply is cut off from that point. And what happens is that the part above the point where the vascular compromise or the blood supply is cut and it is twisted or strangulated, goes into a cell death, which is something we called a gangrene. Okay. And the patient experiences severe pain, a sharp localized pain. And we also say that on examination, the patient has features of peritonism. Okay, peritonism. Because when you touch the patient seems as if he's kind of okay. The moment you take off your hand, that is when the patient screams in pain. That is very, very, very typical of peritonism. Rebound tenderness, it is called. Okay, and these patients can present with fever, and when you check their WBC count, that will also be high in the blood. And if there is mesenteric ischemia, they can have bloody stools as well. Now, there is also chances for perforation in a closed loop obstruction. There is also chances of perforation. All right. So what can cause this mechanical obstruction? So what do you think are the different reasons what can obstruct the lumen of an intestine? What can block the opening of the intestine? Yes, chat box? What all can be the reasons? There has to be some cause in the abdomen which is actually obstructing that intestine, right? So what can be the different causes? Any ideas? We were saying about something inside the lumen or something on top of the intestine, something sitting in the wall of the intestine and going inside. So what can it be? Yes, suggestions? Growth. Yes, Ms. Nancy says it can be a tumor growth, right? Yeah, it can be a tumor growth which is growing in the lumen of the intestine or sitting outside and putting pressure on the intestine and, comprising the lumen. What else? Any more answers? I don't see any answers in the chat box. Yes, what else can be the reason which is causing an intestine obstruction? Yes, Mr. Sumit says it could be a localized infection. The infection which is probably something like Like what? It can be an impaction. It can be worm infestations. It can be an impacted stool, like how Ms. Kanchan was saying. So let us see what it is. Okay. So the intraluminal, that is within the lumen, the reasons can be because of an impaction like stools or some foreign bodies or some vessels, some gallstones, or which is intramural within the wall of the intestine. It can be a stricture when there is actually a less space between the two walls of the intestine. Some reason that at that point the walls have come together, they have come more close. You call it a stricture, or it can be a malignancy. It can be because of cancer, right? Now, you can also have extramural, something sitting on top of the intestine and causing it. It can be some bands or adhesions. Now, these things usually happen in case of multiple surgeries in the abdomen. When someone who has had multiple surgeries, they develop adhesions inside, okay? And that will kink or pull the intestine or cause bands inside, okay? Now, all this is going to not allow a proper movement or peristalsis of the intestine, which can give rise to obstructions. Hernia, volvulus, intussusception, all are other reasons. Now, adynamic causes, like we said earlier, paralytic areas, mesenteric vascular occlusion, pseudo-obstruction are all other causes. Now, I'd ask you, what are the causes, what are the symptoms and signs of obstruction? And you all said abdominal distension, abdominal pain, vomiting. You are all absolutely right. So that is what our next slide is. Okay. When there is a partial or complete bowel obstruction, so when do you call it a partial obstruction? When there is still some space. The lumen of the intestine is not completely closed. There is still some little place left. Okay, that is partial obstruction. When there is complete bowel obstruction, there is totally closed. The lumen is totally closed with hardly any space for the bowel particles to move through. Okay, so when there is a partial or complete bowel obstruction, the patient has colicky pains. Why colicky pains? And what is colicky pains? It is intermittent. They are very crampy kind of pains. And the patient tells you, I have severe pain in my abdomen, but it is not continuous. It comes and stays for a couple of seconds and then relieves, and I'm fine for another few seconds or maybe a minute. And then it comes back again and very crampy. So that is colicky pain. So this is because there is bowel contraction. Okay, so the intestine moves like a wave, and when it reaches a point of obstruction, one wave accumulates one on top of the other and it becomes a colicky pain. Okay, now what happens when there is an obstruction? There is bowel distension. The bowel contents are not able to go forward. And when the bowel gets distended, the gut epithelial surface area also increases. Now, when the surface area increases, there is increased bowel secretions happening. Now, when there is so much of secretions happening, this causes the nausea and vomiting. And why does a bowel distension happen? Because there is decreased movement of the intestinal contents. Now, with all this bowel distension and increased secretions, the patient has vomiting, nausea, and has an inflammatory response happening, which in turn increases the pain of the patient. Okay. Now, how can you understand? I told you earlier that we may be able to tell at the home setting, near the bed of the patient, whether the patient is having obstruction in his large intestine or small intestine. Do you have any idea what it would be? Like you can ask one question and you may know something regarding the symptom of the patient. Any idea, anybody? One more bigger clue, something about the vomiting. What about the vomiting is going to tell you whether the patient has a obstruction in his small bowel or large intestine. In his small intestine or large intestine. Yes. Where do you think is the obstruction? All right. So let's move on and find out. Okay. The level of obstruction determines the pattern of the symptoms. That is, if your patient is having a high level obstruction, that is in the small bowel, in the small intestine, the patient develops the symptom of vomiting much earlier. Okay. And he often tells you, I'm vomiting out so much of fluid. I don't know from where this much fluid is coming. I'm hardly drinking any water, but there is so much that I'm vomiting. Whereas someone who's having a large bowel vomiting might not be probably having so much of volume of vomit as much as the small intestine person. Okay. And large bowel obstructions, usually they are progressive. It develops over a few days. And there is abdominal distension increasing, and finally he develops a vomit, but it is not of that much volume. Okay. Now, when a patient has complete obstruction, the patient does not even pass gas. There is no passing of flatus. There is no passing of gas. There is no passing of motion. Sometimes the patient can have spurious diarrhea. So we did discuss in our last class what is spurious diarrhea. What was spurious diarrhea? Where do you find spurious diarrhea? Yes? Where do you find spurious diarrhea? Today, I'm hardly seeing any answers in the chat box. If you don't want to type, you can speak. So where do you find spurious diarrhea? No answers. Spurious diarrhea is seen in severe constipation. Thank you, Ms. Liana. It is seen in chronic in severe constipation, where the upper part of the fecal mass, it starts necrosing and starts dribbling down. And sometimes the patient is not able to control, right? So he comes and tells you he's having loose stools, but actually it is a severe constipation. So this can even happen in obstruction, okay, bowel obstructions. Now, you were telling me that one of you were telling me that an X-ray will be taken, erect abdominal X-ray is taken. Now, what in the erect abdominal X-ray is going to tell you that the patient is having a bowel obstruction? Oops. What is going to tell you? Yes. There is an X-ray over here. And do you have any idea what is going to tell you in that X-ray? That the patient is having bowel obstruction? Yes? Any idea? All right. So, see, this is a X-ray of the abdomen. And can you see this? These loops over here? I have put a pointer, red pointer here. So this is the large intestine. You can see it is so dilated. And can you see the castrations? You know, these you see that it is not just one single line here. There are some areas that is going in like this. Okay, this is very typical of large intestine. Okay, and now again, you can see that entire size, the diameter of the lumen. It is so huge. There is distension of the intestine. And here, can you see straight line in the bottom? It's a straight line, it's a straight line, it's a straight line, it's a straight line. Now, these straight lines tell you that is there is multiple air fluid levels. The one that you see in the black color is the air. The one that you see in the white color is, below that is the fluid most probably. So it is the air fluid level. Okay, so the black color represents the air, just like how you can see in the top, the lungs, the air is there as well. Okay, and you see the straight lines here, which is the fluid level. So this is very typical of obstruction. Now, so you can do a imaging, you can do a erect abdominal X-ray, or you can do a contrast radiograph. Okay, so you can take a CT abdomen and do a contrast radiograph. All right. So now that you have found out it is a intestinal obstruction, how are you going to plan and manage this? You are at a home setting and you have gone and seen the patient. Patient is having severe abdominal pain, severe distension, not passed stool for the past 1 week, and having severe vomiting. Now, what decision are you going to make? And how are you going to plan if this patient has to be taken to the hospital, or are you just going to manage the patient at home with some medications? Any idea? Anything which is going to tell you what to do? Yes? I don't know if it is my chat box that is stuck, or is it that nobody is answering? Yes, I think everybody is very sleepy today.
Your chat
Are you
box
all
is
there?
perfect, ma'am.
Yeah?
Your chat box is perfect. Please answer. Even my
Yes.
chat box is also coming empty.
Yes, everybody. Do you think, there is something which is going to tell us which patient we should take to the hospital, which patient we should manage at home? Or are we going to treat this patient with some injections, some tablets? What are we going to do? So tell me, how are you going to, what management are you going to do? What treatment are you going to give this patient? Yes, Mr. Sumit says if the vitals are stable, then keep the patient at home. Any other thoughts? Anybody else? Yes? Yes, Ms. Nancy was saying it's definitely a hospitalization because it's an acute, severe situation, so the patient has to be hospitalized. Anybody else? Ms. Aditi says give a liquid diet to avoid complete blockage. So Aditi would like to give some liquid diet. Patient is so dehydrated with all that vomiting. Right. Any other thoughts? We'll send to hospital. Hulasi, Ms. Hulasi says we'll send to the hospital. Ms. Kanchan says give her enema. Yeah, you want to empty those bowels which are so loaded there. So Ms. Kanchan says that we'll give her enema. So let's find out how are we going to manage this patient. Okay? Right. Yes, Mr. Casimiro says, if possible, put the patient on NPO and start home hydration via parenteral. So, yeah, so he says that, yeah, probably we'll put a NG tube into the patient and give IV fluids because the patient is so dehydrated. We will find out. Okay. So the patient who is presenting with symptoms of bowel obstruction, you do a proper clinical assessment. Okay, you look for the abdominal distension. You look for bowel sounds. If you just take the step and place it on the abdomen of the patient and you listen, sometimes you can hear the bowel sounds. If you hear the bowel sounds, it is probably a good sign because there is still some movement of the intestine. If you do not hear any bubble sound, that might be a bad sign because there is no activity over there. Sometimes as you are just standing and looking at the patient, you might see huge wavy-like structure over the abdomen, just moving like that. That's a bad sign. It is because there is a complete obstruction and that the movement of the wavy pattern of the intestine is just mounting one on top of the other, and you can even see it on top of the skin. Now you can see the skin rise and fall, right? And you will hear large sounds, gurgling sounds. It's so audible. You're standing near the bed and you can hear it. That is also not a good sign. Okay. Now, investigations, yes, radiological assessment, you can do an X-ray, you can do a CT. Now, what is your decision-making important points? Whether you want to take the patient to the hospital to do a surgery. If there is an obstruction point with a tumor, maybe that particular area with the tumor has to be cut, removed, and the other two ends has to be anastomosed or stitched together. Okay, so there are some factors. Age of the patient is probably not always a factor because it is a performance status of the patient that actually matters. Age is just a number. Performance status in the sense like how much can the patient actually do? Can he put his own clothes? Can he take bath on his own? Can he even take a spoon to feed himself? Or does he need somebody to do all this for him? So you take the performance status of the patient. Is he able to walk around or is he completely in bed? Look at the stage of the cancer. Is it an advanced cancer stage where no other definitive cancer treatment is possible? Then you will have to think. So that means this patient is a terminal patient. So is it actually justifiable to take this patient to the hospital and get a surgery done for him? So look and find out what is the further treatment, cancer treatment option for that patient, because this is a malignant bowel obstruction. Then also find out how good nutrition, what is the nutrition level of the patient? Is the patient malnourished? Is the patient very thin and frail and cachexic? The patient is not going to withstand a surgery. And what other illnesses does he have? Maybe the patient is having cancer, but the patient also has a cardiac disease, a heart disease. The patient also has a renal problem. He's probably having a renal failure and is on dialysis. So then where is the role of having a surgery done for that patient? Also, that is the patient factors. Now you have the disease factors. How much level of obstruction is there? Is the obstruction at one point or several points? Is the obstruction in the small intestine or the large intestine? Is the obstruction because of a mechanical obstruction? Then you have some chance by just cutting out that point and keeping it away. But what if it is a functional where the nerve itself is not functioning? Then ascites. If there is ascites, it is not a good factor. Carcinomatosis peritoni, when there is so much of metastatic spread all around the abdomen in the peritoni. Peritoneum is like a sheet-like structure which covers all the organs in the abdomen. So if there is multiple small little nodes of secondaries all around in that peritoneum, that again is a bad prognosis. So even those patients cannot be a good candidate for surgery. Okay. And again, you have to think, is your patient good enough to undergo an interventional radiology like a barium enema or an endoscopy or even a surgery like laparotomy or laparoscopy, or will he even withstand anesthesia? Okay. So like we were saying, there are some poor surgical prognosis factors. So if your patient is having an advanced age like 90 years, severely catechic or a very advanced tumor or deranged metabolic parameters like very low sodium, very low potassium, all this very low calcium or high calcium, all this ascites, very low albumin levels. So those with low albumin level have a poor prognosis. Now, severe nutritional deficiencies, then if the mass in the abdomen is so big that you can even palpate it, just put your hand on the abdomen and you can feel the tumor mass. And what if your patient has already received radiotherapy to the abdomen and pelvis or multiple surgeries before? That means that patient is going to have a lot of adhesions inside. So it might not be an obstruction which is just at one point. There will be a lot of obstruction because there are a lot of bands which have been formed inside the abdomen, which is like pulling the intestine. Then history of combination chemotherapy, that is, they have already tried aggressive chemotherapies, then again second-line chemotherapy. And so multiple times they have tried different treatments and all that have failed, which shows it is a poor prognostic patient. And also the performance status of the patient, if it is poor. Okay, so we were talking about what is the treatment. The treatment, right? So some of you were telling enema. Some of you were telling enema. Then what about those patients who have severe vomiting? Okay, so you were telling that we have to hydrate the patient by giving IV fluids, right? Maybe the patient has a very low BP, is severely dehydrated. Yes, we might have to give IV fluids. Then we have to give enema probably after doing a digital rectal examination, taking out the impacted fecal material and then giving the enema or a high-end enema, right? And also corticosteroids. Corticosteroids, why? Why are we giving corticosteroids? Yes? Why are we giving corticosteroids? Any answers? Just a minute. Excuse me. If possible, yes. So why are we giving it? Yes, to reduce the inflammation. Yes, Ms. Pricey and Ms. Lina also agrees to that, to decrease the inflammation, right? So when there is a tumor, right, we might not be able to decrease the size of the tumor, which is closing the lumen of that intestine. But every tumor might have a peritumoral edema, that is an edema around it. So what do? We give corticosteroids to decrease that peritumoral edema. When the edema around the tumor comes down, we get some space in the intestine. So thus, corticosteroids like dexamethasone can be given, and generally it can be given from 12 milligram to 24 milligram as IV once a day, preferably somewhere before evening time, so that it doesn't interfere with sleep. Okay. Now, your patient is severely vomiting, isn't it? So won't you like to give some antiemetics? So what antiemetic would you like to give in your patient who is having an obstruction and is vomiting? Yes? What antiemetic would you like to give? Injection perinom is what? Ms. Aditi was saying, yes, metoclopramide. Yes, Ms. Vineetha also says perinom, that is metoclopramide. Yes, Ms. Aditi says emicit. Yes. Yes, Ms. Kulvinder also says emicit. Ms. Preeti says again ondansetron. Ms. Suman says emicit. Ms. Saraswati says emicit. Yes, we have so many people saying emicit. Ms. Sunita says domperidone. Now, what is telling us to select emicit? What is telling us to select metoclopramide? Ms. Saranya also says emicit. Thank you for all those responses. So what is telling you, okay, let's give emicit to this patient. Okay, let's give perinom to this patient. Or like Sunita says, let's give domperidone to this patient. What is telling you? Is there some deciding factor? See, if it is a partial obstruction, you can give metoclopramide because it is going to stimulate a more forward action, and maybe it will push the fecal mass forward. It will also decrease the vomiting by the forward peristalsis of the alimentary tract. But if it is a complete obstruction, if it is completely closed and you are going to give metoclopramide, what happens when you are giving metoclopramide? The wavy-like actions are getting stimulated, and the first wave goes and hits the point where it is closed, and the second wave comes behind. It gets accumulated on the first one, and the third wave comes, and then like that, it produces colicky pain. Therefore, for complete obstruction, metoclopramide is not given. At that point, you will have to go for central vomiting center inhibitors like ondansetron, or you can try other antiemetics like haloperidol. Okay, and domperidone also, along with metoclopramide, metoclopramide. These two can be given if the patient is having a partial obstruction, and domperidone, which is available only as oral formulation, can be tried if the patient is able to tolerate orally. Okay. Right. So what else? Anticholinergics. The patient is having severe pain. So you might want to give a buscopan or a cyclopan to control the colicky pain. But make sure you are not combining it with metoclopramide because the actions cancel each other. Now, somatostatins. Somatostatins are anti-secretory agents. So like I said earlier, there is bowel distension that happens, and there is increased surface area of the bowel wall, and there is increased bowel secretions that happens. So somatostatin is an anti-secretory agent which helps to bring down the secretions, the production of secretions, right? So like octreotide, right? And the patient is also having severe pain. You can put the patient on analgesic, step 1, step 2, step 3. The choice is yours according to the pain score of the patient. Yes, Ms. Hulasi was asking why haloperidol. Haloperidol is also an antiemetic. We did discuss about that in last class, that Serenase is also given as a antiemetic. Okay, we give it along with patients who are taking opioids. We can also give it for patients who are having obstructive features. Okay. Surgical, so you can do a resection of the bowel segment, you can do a colectomy, you can do a ileostomy, or you can do a colostomy, where the colon is cut or the small bowel is cut. It is called ileostomy. Where the large bowel is cut at the point of obstruction, it is called colectomy. When a part of the bowel is cut, which is obstructed, and removed, and the other part, which is behind the obstructed part, is kept out of the body, it is called a colostomy, and usually a bag is attached to it. Okay. Now there are also invasive procedures like NG tube insertion, like you were all saying. So you can put an NG tube insertion to deflate, to bring down the pressure that is accumulated in the distended abdomen. Okay. Gastrostomy, that can also be done if the patient has a longer prognosis, longer survival, and you want to also feed the patient after that with it. Colonic stent, if the obstruction is only at one point, you can suggest a colonic stent, provided the prognosis of the patient is good. Okay. So, like I said before, metoclopramide, domperidone antagonist, dopamine antagonist. You can start with a 10 mg dose, 8-hourly, and increase it accordingly. Right? I have written the doses here. Then other ways, you can go for a 5-HT3 antagonist and a prokinetic only in partial obstruction. Okay. And haloperidol for nausea and vomiting from 2.5 milligram to 5 milligram. It can be given over 24 hours via a subcutaneous infusion if your patient is having severe vomiting and not tolerating oral. Okay. So 5-HT3 antagonist is ondansetron. Prokinetic is a metoclopramide. Okay. Now anticholinergics, we were talking about buscopan, 120 milligram over a day. Okay, it can be given in divided doses. It can be given IV or subcutaneously. So generally, we tend to give subcutaneous in palliative patients because our patients are weak. Venous access is poor. So we tend to give subcutaneous infusions or injections. And scopolamine can also be given as anticholinergics, but these are not combined with prokinetic. Now, I was telling you about dexamethasone. It can be given as 15 milligram to 24 milligram IV single dose to be given before 3 p.m. All right. And it can be given for a trial of 3 days. You give it for 3 days. You check for the symptom. Is the symptom getting better? Is the patient passing gas? Is the patient passing flatus? And you examine the patient with the step. Are you hearing any bowel sounds? Okay. Is the vomiting coming down? Is the patient able to pass motion? All these are signs that the bowel obstruction is responding, is getting better. So if the vomiting subsides, you can continue as oral steroids. And there is also a role for somatostatin analogs. We did talk about octreotide. It is a somatostatin analog, and it is anti-secretory agent, 300 micrograms per day. You can also try buscopan, which also has anti-secretory properties. Okay. But octreotide is very expensive. That is the only problem. So in a nutshell, this is what your prescription will look like, which to give to a patient who has malignant bowel obstruction. That would be dexamethasone, a trial dose, metoclopramide, or if the patient is having a complete obstruction, do not give metoclopramide. Instead, you can try haloperidol. Okay. And if the patient is having severe pain, you can give hyoscine butyl bromide, which will help to bring down the colic pain. That is buscopan. So buscopan can help to bring down the colic pain, and it is also an anti-secretory agent, which will help to decrease the vomiting. So this is a picture how a stent is inserted. You can see how this stent, it is being put into the lumen of the intestine, and I'll just put on the pointer. Yes, it is put into the lumen. So here is the obstruction. You see that? That is the obstruction, the mass, the tumor mass, which is occluding the lumen. But a stent is being put into, and it is self-expandable stent. So after it is put into, it is expanded. So when it is expanded, the tumor is pushed to the side and the lumen is patent now. Okay. Now coming to that, let's see, what are the common questions that you would face when you are with the patient and the family of the patient? I'm sure that most of you have had experiences in this. A patient is severely vomiting, having severe obstruction features, and the patient is almost terminal with advanced malignancy. And the family is like, there is so much of vomit that is going out. The patient is so dehydrated. Can we give him IV fluids? And what will be your answer? Yes or no? Do we have to give IV fluids for this patient? Terminally ill patient, severe vomiting, severely dehydrated? Yes? Do we give IV fluids? Yes? Yes. Mr. Sumit, Mr. Casimiro all say yes. Ms. Kulvinder, Kaur, Shiny, Nancy, Mr. Dinesh, Ms. Suman, Ms. Sunita, everybody says, yes, we must give. Tulasi, Rafina, everybody says, Evangeline, Maria. So everybody says, yes, we must give. Charani also agrees. So what if your patient is terminal? Your patient is having a very heavy breathing. There is a lot of gurgling sound as the patient is breathing. There is the patient is having, that respiratory secretions also. The patient is having a noisy breathing. Patient is totally bedbound. Just probably another 1 week or less left for the patient. Here is a situation where you have to hydrate the patient just to relieve the dehydration, but do not excessively hydrate for this patient who is terminal, because that can lead to more respiratory secretion and it can lead to more distress for the patient who is terminal. Okay, it can lead to more breathing difficulty. And sometimes it can even add on to the secretions and give rise to more vomiting. So you need to limit your hydration in such a way. And what about oral feeds? Someone who has bowel obstruction, someone who is having vomiting, not able to take in anything, not pass bowels, not pass motion, not pass gas. So what about the oral feeds? The family is so worried. They are asking you, can we give him something to eat? What do you tell them? Yes? What do you tell a family like that? What is your opinion? Should we give something to eat to this patient? Will he be able to tolerate it? No food, because it may worsen the condition, is what Mrs. Sumit says. Yeah, if it is like very solid dry food, it might worsen the situation that he already is. How about fluids? Small amount of fluids. Yes. Ms. Maria says liquid diet. Ms. Nancy says small and frequent liquids, just to keep his mouth wet, to quench his thirst, and just enough which he would tolerate. That is what we usually tell for patients who are able to tolerate small amounts of liquid feeds. Okay. And total parenteral nutrition. What about putting a central line for that patient? Putting the patient on total parenteral nutrition, or putting a peripheric line and giving a pericabivan. What do you think? Should we give that for the patient? Yes, Ms. Hulasi also says giving a sips of fluid. Yes, thanks, Hulasi. And what do you think? Should we put a IV line for this patient and start this patient at home on total parenteral nutrition? Yes, Mr. Dinesh says liquid diet is enough. So total parenteral nutrition is meant for those patients who have a survival or lifespan of more than 3 weeks. So if you find a patient who is almost terminal, about to die in probably another a week or two, that patient is not a candidate for total parenteral nutrition. And maintaining an IV line at home is also questionable. So it is basically total parenteral nutrition is 24 hours, right? It has to run 24 hours. So maintaining and taking care of the IV line is also difficult. So you have to weigh the risk versus benefit. And that is how you decide for palliative. Nasogastric tube or gastrostomy. So I told you earlier, nasogastric tube can be given for deflating the intestine, and need not be that every patient has to be given put a nasogastric tube. You can try with the other medical interventions like corticosteroids, IV antiemetics, and analgesics, anti-secretory agents, and check if the patient is getting better. Prokinetics. And still, if there is severe vomiting, severe distension, you can put a nasogastric tube. And once the aspirate level comes down to minimal, less than 100 ml, then you can, and if the patient is getting better, it can be taken. So can you give anything orally to a patient who is having a nasogastric tube? Can you do that? Yes? Can you give anything orally to a patient who is having a nasogastric tube? Yes? Any comments on that in the chat box? A patient who is having a nasogastric tube wants to eat, have a little of idli. Can it be given? Yes? No? Excuse me. No. എന്തായിരുന്നു പെട്ടെന്ന് പറയും. ഞാൻ തിരക്കാണ്. Yes. Yes, we can put if the patient is conscious. Yes, we can put if the patient is conscious. Sometimes give a sip of water if the patient is conscious. It's what Aditi and Sunita were saying. Sunita and Aditi were saying, and then Nancy says can be given but should not aspirate. Yeah. So if it is like made really mashed, and it is given with adequate fluid, so that he is able to tolerate it and not aspirate. Exactly, like, as you all are saying, if the patient tolerates it, it can be given. Okay. And sometimes, for terminal patients, I did have a terminal patient who was, just had a day or two left, and had a big wish to have biryani. Okay, and this patient is put on nasogastric tube and used to keep saying that, I can't control my hunger. I'm so thirsty. I'm so hungry. I just want to have something and all that. But the family just does not want to give, has got this nasogastric tube, so much of secretions coming into the bag, and expressed his wish to have biryani, which was his all-time favorite. And the family asked me, telling that, after all, this is his last wish. What shall we do? So what I asked to do was that to keep the rice tube open to the bag and give the biryani. So whatever was given, it came into the bag, basically. So it didn't go down his tract to cause him any harm. In other cases, when we are, like how we were telling earlier, generally when we are trying to feed the patient, when the patient has a nasogastric tube, make sure you clamp the nasogastric tube, okay, or you keep it closed. You do not connect it to the bag. So now we come to the story, okay. Sarah is a widower, so basically she is supported by her children, and even her children are not staying with her. They are staying far away in the UK, okay. And she is 62 years old, and she is diagnosed with stage 4 of stomach cancer and having peritoneum and abdominal wall bleeds. Now, what has been done for her? She was done a surgery, that is, the distal part of her stomach was being resected and taken off where the tumor was there, and she was put on chemotherapy. And after 2 cycles of chemo, when a CT scan was taken, it showed that she has progression of disease. Now, what happens is that she developed vomiting and abdominal colic for 2 days, but was still able to pass small amount of stool daily. Her vomiting was 3 to 4 episodes per day, which was unrelated to meals. Vomitus was bilious with partially digested food. So now where is the obstruction? The vomitus was bilious, was yellow color, what she says, and had food particles in it. And it was about 3 to 4 episodes. Yes. Bowel sounds were sluggish. So where do you think the obstruction is? Which part? Small intestine, large intestine? Yes, Mr. Sumit, everybody agrees to that. It is a small intestine. So did you actually need a CT? Did you actually need a X-ray abdomen erect and supine to understand that? No, isn't it? Just a careful understanding of the clinical symptoms and signs, you can pick up where exactly it is. Okay, so now when the patient is having abdominal colic for 2 days, passing small amount of stools daily, it can also be a constipation which is secondary to the chemotherapy. So you can also have a look at that, and that also could possibly precipitate a vomiting. So you can understand whether it is an obstruction by looking at the bilious nature of the vomiting and the partially digested food. Okay. Now, in view of persistent vomiting, a nasogastric tube was inserted. Sarah was told that the nasogastric insertion would be a temporary measure for decompression. Now, a CT scan taken showed a small bowel obstruction. See? Now, a CT scan taken showed the small bowel obstruction, but you were able to understand even before the CT was taken that it was a small bowel obstruction, isn't it? So, as she was still opening her bowels, the impression was a partial rather than a complete bowel obstruction. So, she was having a partial obstruction, right? Because she was still passing small amount of stools. Now, intention of management was to reverse the obstruction. So they thought they will do a conservative medical management for that. Okay. So what was given to her? Suppository bisacodyl, regular interval intravenous metoclopramide, and intravenous dexamethasone 8 milligram per day. She was also started on fentanyl infusion 18 microgram per hour for worsening of nociceptive lower abdominal pain. So what do you think? Is this treatment fine, or did you find any issues with the prescription? Is it fine? Are you ready to go ahead with that? What did the patient have? Abdominal colic, vomiting, not passing complete stools, just some stools. So she was given suppository bisacodyl intravenous metoclopramide and intravenous dexamethasone 8 milligram per day, and started on fentanyl infusion 10 microgram per hour. Are you fine with that? If you're fine, let's go on. So there was no bowel action, and the intravenous metoclopramide was increased to 60 milligram per day on the next day. So the prokinetic, the metoclopramide, which stimulates the forward action, the dose was increased. Now that helped her. Okay, marked clinical improvement 2 days later. NG aspirate was reduced significantly, and she had no more vomiting. And the team doctor was able to remove her NG tube, and Sarah was on oral pills. Intravenous metoclopramide and dexamethasone were also continued for 2 days and stopped. So another 2 days also they gave the metoclopramide and dexamethasone and they stopped it. 3 days later, again the vomiting starts. And she was recommended, she was recommenced on IV metoclopramide 60 milligram per day, dexamethasone 8 milligram per day, and IV ranitidine was added to reduce the gut secretion. So in spite of all that, her symptoms persisted. So what do you think went wrong here? Why did she develop it all of a sudden again in 3 days' time? Do you have any idea? Yes, in the chat box. What is it that happened that she developed her symptoms right away after 3 days? Something? What do you think about the dexamethasone dose? 8 milligram. Do you think that is sufficient? No, that is not sufficient per day. You might have to have at least 16 milligram per day or once daily to have a management, an adequate management for malignant bowel obstruction. Yes, but preferably not 3 times daily, because dexamethasone has a long time duration of action. Okay, so you need to give it only once daily. Okay, and you can give 16 milligram or 24 milligram IV once daily, preferably before 3 o'clock. Okay, and also do not stop abruptly. The antiemetic was stopped abruptly. The corticosteroids were stopped abruptly. So it would be good to taper it down and stop it. Okay. So now, because her symptoms were persisting, the goal of care was established after discussing with the patient and her family, and she preferred to keep the nasogastric tube for decompression while she enjoyed taking fluid orally, even with the nasogastric tube. Decision was also made to stop further chemotherapy for comfort care, and she returned home with home hospice support. So now this is also a scenario that we usually see in families where the family is abroad. They provide the money, resources to give the best treatment possible, to give the most aggressive treatment possible. And this lady who was here in India happened to be getting all possible treatment, chemotherapy, surgery, but although she was having an advanced cancer. The goal of the care was discussed with the family only much later. And once the goal of care was talked to about keeping her comfortable with medications rather than going for chemotherapy, which is not having any action on her disease, they finally came to the decision of home hospice. Okay, now just 2 slides to 3 slides on bowel irrigation. That is those patients who are having a colostomy. Okay, those patients who are having a colostomy, they have to undergo bowel irrigation technique. Why? Can you tell me why? Why do you advise patients with colostomy to do bowel irrigation? Can someone please put it down in the chat box? You know, we had an orthopedic surgeon who was having a colon cancer, and he had to undergo colostomy, and he had a bag with him. He had completed his chemo surgery, everything, but he had the bag. And every month he came to follow up. Once I was talking to him and he was telling me how he is, just so confined to home. He had gone into depression. I asked him why he was not getting back to work, and he said he would never be able to get back to work because he had the colostomy. And obviously, there is always, contents, bowel contents coming into the bag, and the bag might just get filled up. Sometimes it might overflow and it starts smelling. He did not want to do that, being an orthopedic surgeon, having to spend so many hours in the OT. So that is when we advised him on bowel irrigation. And he practiced bowel irrigation and he was able to get back to work happily. Yes, Ms. Shiny says it is flushing. It is a flushing of the intestine that is done every day at the same time, continuously for about 21 days to 28 days. And then it becomes a habit for the bowel to flush at that particular time of the day daily, even without doing the irrigation. You're conditioning the bowel to form a habit like that. Okay. So this is the different things that we use for a bowel irrigation. You have an irrigation bag, you have a tube connected to it with the tip being a cone tip. That cone tip is inserted into the opening of the colostomy. And then you also have an irrigation sleeve into which the flushed contents are going to fall into. Okay, so this is how it looks. You irrigate, you fill the irrigation bag with lukewarm water, and it is clamped, it is connected, and the conical tip is put into the colostomy, right? And once the fluid is completely filled into the intestine, it is removed, and then the sleeve is attached to the colostomy end, and it is flushed into. And what happens? The entire contents of the intestine gets flushed into the commode through the sleeve. That is what you see in this picture. So now what we have learned for today is a classification of intestinal obstruction, the symptoms, diagnosing. Now you know how to diagnose whether the obstruction is in the small intestine or large intestine. And now you know also how to manage such patients, who to manage with surgical, who to manage at home, and what to give for a patient who is managed it. Thank you. Yes. Now we may proceed for the presentation for today.
Yeah, ma'am.
And any questions will be taken after that.
Yeah. So we have another 2 minutes for we can move on to the case presentation now. And in the meantime, if you have any questions, please put it in the chat box. Suman will be presenting a patient story.
Good evening, ma'am. Today I am presenting patient name Mrs. X, 65 years, female. Diagnosis was hypertension, diabetic mellitus, intestinal obstruction associated with umbilical hernia. Presenting complaints: patient cramping, abdominal pain on and off, loss of appetite, constipation, vomiting, inability to bowel movement, swelling of the abdomen. Patient have been complained of vomiting and severe abdominal pain and shifted to ER department at night time. History of illness: patient got admitted in hospital for complaints of cramping, abdominal pain on and off since 1 month, loss of appetite since 10 days, constipation lost 5 days, vomiting lost 2 days, inability to bowel movement or causing gas, swelling of the abdomen girth is 45 centimeter. Known case of DM hypertension on medication. Surgical history was LCS done at age of 28. Menopause attended 20 years back. On examination, patient temperature 98.6, respiration 24 per minute, BP 140/90, or pulse rate 88, SpO2 98% at room air, height 154 centimeter, weight 62 kg, cardiac S1 S2 present, respiratory system no abnormalities, skin dryness present, abdomen distension present and with tenderness, CBG 140 mg per dl. Blood investigation and HbA1c 7.2%, FBS 100 mg per dl, ppbs 140 mg per dl, urea 22, creatinine 0.8, abdomen USG abdomen done, abdomen shows umbilical hernia. Psychosocial aspect, client having anxiety due to clinical progression of the disease, client worried about the family financial condition, self-isolation due to disease condition, she is more dependent her ADL, which cause of stress and depression, family members very upset and anxiety about client condition, psychological support given and family counseling given. Medication during hospitalization, doctor advice injection pan, injection emicet, tablet amlong 5 mg BD, tablet metformin 500 mg BD, injection diclofenac with 100 ml NS. After patient not willing for further management, so after discharge at doctor advice, tablet amlong 5 mg, tablet metformin 500 mg BD, tablet emicet 4 mg TDS before food, tablet pan 40 mg BD half an hour before food, tablet Ultrasec TDS. Main concern, she was an active homemaker, or after escalation, she get anxiety due to disease condition, monitor SpO2, CBG, pain management, weakness due to poor intake, lack of activity intolerance, risk for fall, need to do meet her elimination problems. Summary: fluid replacement, nutritional management, pain management, psychological support. Discussion point: infection control, nutritional support, pain management, health and safe environment, family counseling. Thank you.
Thank you, Suman, for the presentation. Anybody need any more clarification regarding this patient story? Please ask. So I think no more further points to needed for everyone. So we can move on to the discussion points. So as I said last session, so we would like to hear from you all. So if you have seen this kind of patients in your settings, how will you manage? So either unmute yourself and talk, or you can put your answers in the chat box. What do you think?
Actually, hi, Sumant. Thank you for this case. I was just wondering, this patient was sent home. No surgery was done for her. She is having an underlying diabetes and hypertension.
Yes, ma'am.
And she appears to have a strangulated hernia, umbilical hernia.
Yes, ma'am.
And she was managed conservatively.
Ma'am, hospitals say convinced, but they are not willing for further management.
Oh, okay. The patient and family was not willing for further management.
Yes, ma'am.
That is why she was brought home.
Yes, ma'am.
Did they, the patient was also told by the treating physician that it was highly fatal if she does not go for the surgery?
Ma'am, we informed, but patient not that much knowledge, ma'am.
Okay. Right. Yeah, so is she able to take anything orally?
Yes, ma'am. Only liquid fluid.
So I would like to ask everybody about the discharge at home prescription. Can you just change to that slide, Suman? Discharge at home.
Sripriya,
Hello, ma'am, is the slide changing?
I think
Yes.
slide 7 or something.
Hello, ma'am.
When the patient went on discharge, she was put on some medications, no?
This one.
Yes,
That's
yes,
right. Yeah,
Is it
this one.
visible now?
Yeah.
yes.
Sorry for the technical glitch.
Yeah. So the patient was having vomiting, constipation, and abdominal pain, and also not even passing gas. That is complete obstruction. And the prescription is not showing any dexamethasone or anything, not even to decrease any edema. And pantoprazole is being given, Emicet is being given, diclofenac is being given. And the patient is also put on pantoprazole, Emicet, and Ultracet. Now that is a discussion point I would like to bring here. If everybody is convinced with that management. So by the time this patient was discharged, was she passing stools? Suman?
Able to pass, ma'am.
Huh?
Able to pass.
Able to pass.
Like-
Okay. Right.
Suman, I would like to ask one question. So, did you contact her again after discharge?
Sorry, ma'am.
So, did you contact her again after discharge? How is she right now?
Yeah, ma'am. I had called, ma'am, but they didn't attend phone, ma'am.
So, who is the primary caretaker for that patient?
His son, she.
Her son.
Yes, ma'am.
So you were saying that her main concern is pain management. Was she getting adequate pain relief with Ultracet TID?
Sorry, ma'am.
Was she getting enough pain relief with Ultracet TID? She was put on Ultracet TID, right?
Yes, ma'am.
So she was getting good pain relief with that?
Yeah, yes, ma'am.
So then that her pain is well controlled, so that is not anymore her concern. So then it is her weakness and her poor intake. And the weakness which is contributing to lack of activity, intolerance, and the weakness which is also giving her fear for the risk of fall. So we have to advise her regarding her nutrition, right?
Yes, ma'am.
Yeah. So what kind of nutrition will you advise for this patient? Yes, this is for everybody.
High fiber diet, ma'am.
Huh?
High fiber diet, ma'am.
Um,
Fiber diet.
actually, why do you give high fiber diet? What is the
Constipation.
principle behind it?
Prevent constipation, ma'am.
Yeah, for constipation, we give high fiber diet. I agree. But when do you give, like, what is the action when you give high fiber diet? When you give high fiber diet, the bulk of the stool increases. Okay. So when the bulk of the stool increases, that stimulates the forward action and promotes intestinal motility and elimination. Okay. So when there is already some compromise in the lumen, when you know that the space is less, it might be advisable to avoid high fiber diet. Okay. So it is better to resort to other type of laxatives, like contact laxatives or osmotic laxatives.
Okay, ma'am.
Or softness, stool softness, right?
Okay.
Then pain management. If she is already passing stools and all that, you can go for antispasmodic, like anticholinergics like buscopan and all that. That is not a problem. Then family counseling. What kind of family counseling will this patient need? You told that the family members are very depressed and anxious about the patient's condition. So what will you do? Yes, what should we be doing? Let's put it across like that. We are all together as a team, right? So what should we be doing for this patient's family? Yes? What type of counseling should we then be giving?
Improve the knowledge, ma'am, about disease condition.
Huh? Yes? Anybody can answer. You can put it on the chat box or you can just say it. You can unmute and talk. You need to find out what exactly is the patient's concern. Does she feel that she is going to die because she is not being denied, because she is being denied of further treatment? Did she not want the treatment or did the family not want the treatment? Did she actually want the treatment, but she said no because she thought that it would be a financial burden for the family? What does she see as death coming? What symptoms does she have in her mind to think that these are the red flag signs which mean that my death is near? And that is what she's fearing. Explore, ask, talk, find out, explore what are the type of fears that she has. Talk with the family. What is the issues concerning their fear about the patient? Do they have guilt? Have a family conference. Sit with the patient, with the family, all of you together, and talk about the concerns. Tell her that she is passing stools now. So her pain is well controlled, which is a good sign. At least for now, things are in control. So try to give her some hope that, things are not as bad as what she thinks right now it is. Any more? Do you think that anything more has to be questioned or looked into?
No, ma'am, I think you have covered all the points. So, as you mentioned, if they are reluctant to do the conservative management, you have to identify the cause, why they are reluctant to do the treatment. So, we need to explore the cause, and if we are able to manage this, you can try to manage that problem. So, our duty is to identify the cause first. So that is very, very important. If there is any curative possibility there, definitely we will do something for her.
Yes.
So our aim is to improve the quality of life of the patient and the family. But at the same time, we need to manage if there is any need to think about the curative and possibilities also.
Yeah.
Try to conduct family meetings and make them understand well about the curative part and what are the do's and don'ts. That also you have to tell the caregivers too. So then they will understand more about that, and then they will come with a good that maybe they will be taking a good decision for that loved ones. So.
Right.
So, I think no more questions. We can wind up the session now. Can I?
Anybody has any questions regarding
Yeah.
this case or today's session?
I think no questions, ma'am. Okay. So we can wind up the session. Thank you, Vineetha ma'am, for the wonderful session. So it's a excellent learning session because this is a new session for all of us. So especially intestinal obstruction. So we had a good session. We have learned a lot. I hope they also have learned a lot for today's class. And thank you, Suman, for a case presentation. So we need to, if possible, you can make a call to the patient and find out how is she right now. Is there any further treatment needed? That also you can find out. And let us know. So if you have any help, if you need any help, please call us. We will try to help you. Thank you all for joining today's session. Once again, thank you, ma'am. Thank you.
Thank you, Valiant, and thank you to all the participants. Thank you, Shiva sister, and to all the participants. You all have been very encouraging by giving your answers here on the chat box, because it makes the entire learning process mutual. When you put in your points and I put in my points, learning becomes mutual, and that's exactly the way to go for. Thank you, everybody.
Thank you, Dr. Vineetha, for joining us, and thank you, participants. So, with a positive note, this is Sri Priya, along with Dr. Vineetha Rijju and Sister Shiva, signing off from the Tips Eco Hub. See you all in the next session. Till then, everyone take care. Bye-bye.
Okay. Bye-bye.